I think we'll go ahead and get started. I know it's a lovely afternoon, so it's really great to see everyone down here for a discussion this afternoon. My name is Catherine Bliss, and I am a senior fellow and a deputy director with the CSIS Global Health Policy Center. And it's really a pleasure to see all of you. The topic of today's session is social franchising and health. Specifically, we will be looking at the emerging challenge of non-communicable diseases in the developing world, and the role that the private sector in general, and social franchises in particular, may be able to play in addressing them. Now, the role of the private sector in providing healthcare is certainly well known. We spend a lot of time talking about the role of the government in providing healthcare, but in some world regions, over 50% of household expenditures on health go to private sector entities, such as clinics, hospitals, pharmacies, or NGOs. According to a 2007 WHO report, in many Asian and Latin American countries, the private sector provides more than 50% of all contraceptives. And in sub-Saharan Africa, around 30% of family planning methods are procured from private sector suppliers. And this trend is not limited to reproductive health. Nearly half of the most impoverished quintile of the population in sub-Saharan Africa who sought remedies for childhood diarrhea did so from a private sector institution, according to one survey. So social franchising, we're going to hear a lot more about it in our discussion in a few minutes, but has been defined as a business model that involves building a network of outlets or franchisees that are locally owned but act in a coordinated manner with the guidance of a central headquarters or the franchisor. And so in this setting, the franchisor maintains quality standards, provides training, and conducts centralized purchasing and promotes a common brand. In a business or commercial franchise, that relationship between the franchisor and the franchisee may be contractual and involve the franchisee buying into the franchise and paying fees, and it's generally a profit motive. In a social franchise situation, the franchisor is more often an NGO or a nonprofit, providing access to commodities or supplies at lower costs. The franchisee may pay fees and ensure a standard quality of care to clients, and they may report data and service statistics to the franchisor. But in that arrangement, the motive is improving social well-being rather than profit-oriented per se. Now, evidence from developing countries suggests that social franchising as a concept has worked well in terms of improving quality of care, access, and affordability for the most vulnerable populations, particularly with respect to reproductive health care and tuberculosis treatment. So the overarching question we wanted to tackle this afternoon is whether the concept can be applied to the non-communicable disease challenge. If so, what would that look like? Under what conditions might it work best? What might be some of the challenges or drawbacks? And to discuss some cases where this has already been tried and to discuss some lessons learned. And of course, these are relevant questions as we look ahead to the high-level UN meeting on non-communicable diseases to be held in New York this coming September. Now, fortunately, we have with us today an expert panel to provide some background information and to help begin a discussion and to explore these questions. I am pleased to welcome Nikki Charman, Rebecca Firestone, and Gina Lagomarsino here to speak with us this afternoon. And you should have received a copy of their full bios at your place or when you came in. So I won't repeat all of the information you have there, but let me tell you a little bit about each of them. Nikki Charman works with Population Services International, or PSI, as the Global Services Marketing Manager and leads PSI's social franchising initiatives worldwide. She's based in Nairobi. I think that's right, yes. Rebecca Firestone is a researcher at PSI, specializing in sexual and reproductive health and non-communicable disease. A social epidemiologist, she is based here in Washington, D.C. And Gina Lagomarsino focuses her work on health systems design and financing as a managing director at Results for Development. She has a background in business administration and previously served as senior health policy advisor to Mayor Anthony Williams here in Washington, D.C. So Rebecca will start us off with a discussion and an overview of the NCD challenge in developing countries, and she'll be followed by Nikki and Gina with a discussion of social franchising and its potential applicability to NCD issues. And then from there, we'll open for discussion and questions. So let me turn the table over, please, to Rebecca.
Thank you, Catherine, and good afternoon to everyone. Thank you all for coming. We're hoping to stimulate a lively discussion about some of the intersections between social franchising and NCDs. So I'm going to start out with the epidemiology and some of the policy context about why we're talking about NCDs. And there's three things that I'm hoping to come across in the next 15 to 20 minutes. And one is that non-communicable diseases are a major health challenge for low and middle income countries now. It's projected to get worse into the future. There are effective and cost-effective approaches to address, to both prevent and treat many non-communicable diseases in developing country and low-resource settings. And we need to start thinking about opportunities and strategies for integrating that into the existing platforms that we have within the global health community to address the current diseases, which are a major focus. So, as long as this works. What are we talking about when we mean non-communicable diseases, and why are we talking about it? The primary impetus right now for conversation on non-communicable diseases is the upcoming UN high-level meeting in September, as Catherine suggested. And this is in a way similar to the 2001 summit on HIV/AIDS held at the UN. The non-communicable diseases themselves are a somewhat broad term, and just to focus it down and sort of get us all on the same platform, usually we're talking about cardiovascular disease, cancers, chronic obstructive pulmonary disease, and diabetes as the major non-communicable diseases of focus. And those are likely to be the diseases that policy and strategy will focus on at the UN meeting. The UN meeting does follow on several other major policy initiatives that have occurred around the world of non-communicable diseases. Most notably, in 2003, the Framework Convention on Tobacco Control was introduced, and this is the world's only public health convention, or sort of treaty, in the world. And that was a major impetus focusing on tobacco. But right now, if we actually look at the priority within the global health community that is given to non-communicable diseases, if we just look at overall development assistance for health as kind of a measure for priority setting, in 2007, less than 3% of all development assistance for health was dedicated to non-communicable disease. So that was less than $1 per disability-adjusted life year dedicated to non-communicable diseases, compared to about $24 per disability-adjusted life year to HIV, TB, and malaria. So there has been discussion around non-communicable diseases, but it has not yet led to much in the way of action. So why the focus? I'm going to go through and show a little bit of the epidemiology based on estimates from the World Health Organization. And non-communicable diseases are leading causes of death now and likely well into the future. NCDs account for 60% of all deaths globally, and 80% of those diseases occur in low and middle income countries. So this figure here shows mortality rates across different regions of the world. If you can, I'll see if I can get my neck to stretch back and forth here. So the blue are communicable diseases, red is non-communicable diseases, and green are injuries. And these are categories that the WHO has set up to organize causes of mortality and morbidity. And the blue category, communicable diseases, maternal and perinatal, and nutritional deficiencies, stand out. But what I really want to show you on this slide is basically that the red, which are non-communicable diseases, are a large proportion of overall mortality rates across regions of the world, and that red proportion is just going to get bigger, projected to 2030. And this is despite the fact that in some regions of the world, overall mortality rates are projected to decline between 2004 and 2030. The proportion attributable to NCDs is expected to increase. So 2004 is the last year for which we have comparable data across countries. And I wanted to go through and look at what the actual causes of death in 2004 were. So can I get any guesses from the audience about what the leading causes of death were? Okay, cardiovascular? Traffic accidents? Others? Okay, yeah, chronic obstructive pulmonary disease. Okay. Here's the actual rankings, top 5. So we got some of them: ischemic heart disease, cerebrovascular, so stroke, lower respiratory infections, chronic obstructive pulmonary disease, and diarrheal diseases. So 3 out of the 5 main causes of death in 2004 were non-communicable. And besides just looking at mortality, NCDs are also a major cause of disability in 2004 and projected to 2030. So this is because there is a chronic element or sort of a long-term element to many of the non-communicable diseases that we're looking at, that they are likely not just to be causes of death, but to be causes of illness prior to death for an extended period of time. Then going into sort of what's causing some of this, there are a handful of modifiable risk factors, about 6, which are attributable to for most of the non-communicable deaths in the world. And these are, starting over on your left, high blood pressure, tobacco, high blood glucose, physical inactivity, and overweight and obesity. And I've also added a few other major causes of disability here, so unsafe sex, alcohol use, underweight, unsafe water, sanitation, and hygiene. And you can see that high blood pressure is really the big one across regions of the globe, that the majority of, this is the leading risk factor for non-communicable diseases. Tobacco itself accounts for 1 in 6 of all NCD deaths, and 3 of those risk factors are actually related to diet. So blood pressure, blood glucose, overweight, and obesity. These are all associated with nutrition. So we can look at a handful of modifiable risk factors and think there's something that we can focus on. If we focus on diet, physical activity, if we focus on tobacco, those are things that we can get a handle on. But there's actually some underlying causes that are at play that are contributing to why we see a rise in those modifiable risk factors in developing countries. And those are things like, for one, population aging. As the population just gets older, the chronic diseases are likely to become more prevalent. But other factors like rapid urbanization, agriculture subsidies of tobacco, corn, and soy, and the role of multinational corporations looking for expanding markets in developing countries are all factors that are contributing to sort of underlying what we see is the growth in modifiable risk factors. So although some people might say, frequently term non-communicable diseases as lifestyle diseases, there's actually, and suggest that there's a matter of individual choice involved. If you actually look at some of these contextual processes, it's not just about individual choice. So I've tried to lay out some of the epidemiology and why there is an existing burden. The question is, why has there been so little action to date if based on the evidence? And I'm going to reference Julio Frank, who's a major global health leader who's been speaking about non-communicable diseases recently. And he suggests that there's a set of misconceptions in the conversation in the global health community which are likely focusing on why we haven't really focused on NCDs too much to date. And this is in some ways kind of somewhat similar to the conversation we were having around HIV back 10 years ago. And that's one is that it's not a problem, or it's not that NCDs are not a problem for developing countries, because these are diseases of affluence or individual lifestyle choices. So I tried to present some data to suggest that that's not the case. We can discuss this more. Even if we accept that NCDs are a problem for poorer countries, we might think that it's not that important, or that it's too complicated to do something around NCDs. These are chronic diseases. It's going to involve real investment over the long haul to deal with these diseases. So what can we do? So we'll address that. And then even if we felt like there was something that we could do about NCDs in low resource settings, it's going to be too expensive. So I'm going to go through and try to address some of those statements. And I'm going to start with some data from Southeast Asia, which is a region of the world that I know best. And I think it's also interesting because Southeast Asia encompasses countries from the lowest income in the world to the highest income in the world. So it's a good kind of microcosm of what's going on. And if we look over here on your left, I have non-communicable mortality rates mapped against gross national income down here on the x-axis. And over here is NCD deaths as a proportion of overall mortality within those countries. And then on the right, we have NCD death rates themselves. And so on the left, you can see that as a proportion of overall deaths, NCDs decline. They increase by income. So there's more NCD deaths proportionately in Singapore than in Laos. But if you actually look at the absolute mortality rates, the NCD mortality rates in Laos are higher than they are in Singapore. So that suggests that this is not just diseases that affect only wealthy countries. If we break it down even further, we can look at risk factors for non-communicable disease deaths in the same set of countries and see that if you disaggregate by socioeconomic status, for some risk factors, it's very clear that the poor are actually disadvantaged. And that's clearest for tobacco. Again, let me see if I can go over here. We've got Malaysia, Philippines, Vietnam, Laos, and Myanmar are the columns here. And at the top, we have wealth quintiles from the poorest at the top in blue to the wealthiest in the light purple. And you can see that there's a gradient where tobacco consumption is highest amongst the poorest quintiles across all of these countries in Southeast Asia and lowest in the wealthiest quintiles. The pattern is less clear for insufficient fruit and vegetable consumption, but there's some evidence of a gradient where the poor are actually consuming less of a healthy diet than the rich. And the pattern may be somewhat reversed for insufficient physical activity. But what I just wanted to indicate here is that across many different Southeast Asian countries at different levels of economic development, some risk factors are disproportionately disadvantaging the poor. So we have evidence that poor countries are affected by non-communicable diseases, and we have evidence that poor populations are disadvantaged within those countries in non-communicable diseases. Some further evidence as to why NCDs are a development issue is the link to poverty. So chronic illnesses themselves are a major cause of catastrophic expenditures within households because of the chronic illness, the chronic nature of it, that there's just going to be an expenditure over time. And if you're paying out of pocket, it's going to be an increased burden on the poor. Poor people are likely to have worse access to health services to begin with. And so that's evidence of at the household level of the likelihood of NCDs involving people in poverty traps. On the macroeconomic level, there's some evidence to suggest that NCDs and the burden of having to treat these non-communicable diseases over time are associated with reductions in economic productivity. I would say that there is a need for better research on the economic burden of NCDs. There's some initial evidence out there, but it's spotty. But the evidence to date suggests it's not a good picture. So that's to suggest that we need to do something, particularly if we're concerned about the health of the poor and the most vulnerable, to focus on NCDs. And this slide is to indicate that there are a handful of effective and cost-effective interventions have been identified and costed. The costing here was for 23 of the highest burden countries in the developing world, and these included countries like India and China, but also Brazil, Nigeria, South Africa, and several others. And this suggests that these interventions for risk factors of tobacco, dietary salt, unhealthy diet and physical activity, alcohol intake, and then treatment of cardiovascular disease are likely to be of a minimal cost. So for tobacco, we're talking about ensuring implementation of the Framework Convention on Tobacco Control, which includes efforts such as tobacco taxes and much more careful regulation of tobacco marketing. Those are some of the items. And that is projected to avert 5.5 million deaths over 10 years. For salt, we're talking about reducing salt consumption on a population level through things like voluntary reformulation of processed foods, just to take the salt out of the cans of fruit or vegetables or bread, and as well as media campaigns on salt reduction. And that has been estimated to avert about 8.5 million deaths in some of these in over 10 years in the highest burden countries. For obesity, we're talking again about regulation and taxation strategies. Same for tobacco. On risk reduction for cardiovascular disease, some work has been done to look at a very low-cost regimen of a statin, aspirin, and a couple of hypertensive drugs that could be introduced at a primary care level for about $1.08 per person per year. And if you did opportunistic screening of people for risk of cardiovascular disease and provided this type of low-cost regimen, it's been anticipated it could potentially avert about 18 million deaths over 10 years. So these are potentially really big wins if we think about how to implement them. PSI itself is an organization, and I'm going to say that there are several PSIers in the room who can chime in on some of this work as well. PSI has been thinking about how to approach the non-communicable disease burden through a few different types of interventions around tobacco control and obesity, and then social franchising. I'm going to leave that to Nikki to talk about. She's going to mention a little bit of the work there. So I just want to leave us with, I think, in terms of stimulating a conversation into the future in this panel, is to think about non-communicable diseases, not just from the epidemiology or the policy level, but how are we going to respond on a health systems level? And from there, I think we need to really be focusing on the fact that a continuum of care is required to follow through the full life cycle of disease, from prevention all the way through to palliation, is going to be necessary. We have to prevent the coming increase in the burden of disease, but there is an existing population of people who are in need of treatment right now, and are in need and palliation and sort of pain relief for human rights purposes. I think there's two things that we need to be thinking about getting our heads around for that. And one is on the prevention side, we need to be thinking about extending beyond the health sector. That some of the most effective population-wide prevention strategies are going to require engagement with people in ministries of finance, in ministries of trade, and urban planning. And we need to think about how, as people who are accustomed to working within the health community, we're going to start to make those conversations and coordination happen. Within the health system, we need to be thinking about stronger health systems for non-communicable disease, because that chronic element of non-communicable diseases is critical. That if we're doing our jobs right, we'll be able to ensure that some people have access to care over the long term, because many of these diseases are eminently manageable, even if you have them. The opportunity there is that through integrating approaches to NCDs into existing health systems, that is likely that we can end up with stronger health systems that will benefit other diseases as well. So I'll leave it there and turn it over to Gina and say thank you.
Apparently it's easier if we are sitting over here for the webcast. So let me pull this up. Great. Well, it's great to be here at CSIS, and actually quite humbling to get invited to speak on this topic, because our two topics are social franchising and non-communicable disease, and I don't consider myself an expert in either of those two topics, but I'm hoping that I can maybe provoke a little bit of a discussion here by talking a bit about some of the health systems challenges that a number of countries in the developing world are facing, especially those countries that have highly marketized health systems with a lot of private sector activity, and how they're going to address NCDs. And then secondly, to talk about what we're actually seeing in terms of a few emerging models that are already addressing NCDs in developing countries. And a few of these are franchises. A lot of them are not franchises, but they may have lessons for how franchising might evolve or how other models for NCDs might evolve. So first, I probably review for most people in the audience, and as Catherine mentioned at the beginning, many countries of the developing world, people who are going to seek care, regardless of whether it's a communicable or non-communicable disease, are likely to go to a private provider. And there's going to be a full range of private providers that they'll have a choice from a high-end private hospital in a capital city to a small clinic in a secondary city to an informal provider in a rural village that may not have any training or much training at all. So a lot of people are seeking care in the private sector. As Catherine mentioned, there are 33 countries, as reported most recently by the WHO, who now have out-of-pocket spending greater than 50% of total health expenditures, and almost all of these countries are low, middle-income countries. They also, I might add, many of the countries on this list are the largest countries in the world, such as India, Pakistan, Nigeria, Cambodia, et cetera. So there's a lot of people living in highly marketized systems, so it's very likely that someone with a non-communicable disease, their first point of contact is going to be a private provider. And as we've mentioned, social franchising is a model that has the potential and has been shown to improve quality of private providers by standardizing care. And so I think it's definitely a model that we need to be thinking about as a possibility for NCDs. In terms of health markets generally, so when you've got a situation where you've got a lot of people who are paying out of pocket for care and have a choice of multiple fragmented private providers, you face a lot of challenges in actually coordinating and providing comprehensive care for these folks. They've got the choice of a very fragmented set of providers, often informal. There's often very few standards and little oversight. Consumers aren't well trained about what it is that they need to be going to seek. They don't know that they need necessarily screening for hypertension, diabetes, et cetera. We see a lot of unnecessary and harmful care getting delivered, people getting prescribed steroids when they really are diabetic, et cetera, either because you've got private providers that are not well trained or because they're taking advantage of the fact that the people that they're treating don't know a lot. And then clearly you have affordability issues, people that can't get care because they can't afford it, or they're being impoverished further because they're actually paying for care that they can't really afford. And then finally, of course, there's a lot of proven interventions that aren't actually being received because the people don't know to demand them and the providers aren't necessarily incentivized to provide them. So this is true for communicable diseases, for maternal child health, et cetera. But in the case of non-communicable disease, I think it raises some particularly interesting challenges. So I'll bring up a continuum of care that's similar to what Rebecca just showed us. Clearly, if you really want to provide good care for chronic illness, you've, number one, got to start with primary prevention, which is a little bit even outside of the health delivery system, but that's key. You need to do diagnostic screenings. And one challenge, of course, is that a lot of the early symptoms of many of these diseases there's not really early symptoms. So people are asymptomatic and they don't know to go get a screening, and there's no health system that's going to pull them in to get screened for things like high blood pressure and diabetes. So how are we going to make sure people get screened early before their diseases get out of control and get very costly and debilitating? Then you've got to monitor people on an ongoing basis. If you've got a chronic illness over a period of many years, you need to be able to figure out, make sure that person is staying in control, especially for diseases like high blood pressure, hypertension, and diabetes. Then you need to have acute treatment available, hospitalization, surgery in some cases, other kinds of high-end treatments for things like cancer. And then you'll need long-term treatment for some diseases, which can be everything from relatively simple medications, like the regimen that Rebecca was describing, all the way up through dialysis for multiple years. And then clearly, in an ideal world, you also want to have good skilled nursing, palliative care, things like that for people that are getting close to the end of life or coming off major acute episodes. So this is a pretty complex thing that we need to deal with, and in the context of many health systems that are quite chaotic and fragmented and very much driven by individuals going to seek care when they feel like they need it, and providers that are not well coordinated. So some of the key challenges I think that we all need to be thinking about are, number one, in this world where patients are primarily paying out of pocket for health care, they don't have, what we know is that people don't typically spend a lot of money out of pocket for preventive screenings. They tend to go for curative care. So it's unlikely that people are going to be paying a lot of out of pocket for screenings, let alone even knowing that they need to go get a screening. The fragmented systems that we have, which are both fragmented in the sense that there's a lot of kind of mom and pop care, very small scale clinics, and across the continuum of care, we have, everything from drug shops to hospitals, but that are not necessarily well coordinated between them. These fragmented systems means there's few standards and protocols that are in place, and a lot of these chronic illnesses really require that treatments according to very standardized protocols. It's really difficult to track and manage patients over time when they're bouncing around to different providers over the course of an illness. And it's, of course, difficult to coordinate across the care continuum when you don't have really good mechanisms for referrals, and there's not a lot of connection across the continuum. Another, of course, issue, we have the problem of human resources for health in underserved areas in the developing world. There are a lot of diseases for which specialized physician care is required, and that's, of course, not available in rural areas. This is an issue for communicable diseases and in maternal child health as well, but one for NCDs. And the financing issues, I think, are huge here. The fact that we have lack of prepaid, risk-pooled financing for care, where people are going to need treatment over the course of many, many years, makes it really tough to finance these kinds of things. And I think Rebecca pointed out that it doesn't have to be super expensive. There are things we can do on the prevention side, but if we are going to be able to provide comprehensive care to people, we really need to think about how to finance care better and move away from the norm, which is out-of-pocket spending right now. So we at Results for Development about a year ago launched something called the Center for Health Market Innovations. And what we've been doing is attempting through a network of partners in a number of regions of the world to identify innovative models that are policies and programs that can be implemented by governments or nonprofit organizations or businesses and social enterprises. We're looking for these programs and policies that help to improve the performance of the healthcare marketplace. Assuming that there are a lot of private providers and a lot of private transactions, how can we get this healthcare marketplace to function better? So we've been out there scanning the globe with the help of our partners. We've documented now getting close to 800 programs around the world. And as you might expect, the majority of them are for things like HIV/AIDS, TB, malaria, maternal child health, immunization, et cetera. But we do have a growing number of innovative models that do address non-communicable diseases. It's a small percentage of our overall database, only about 5%, but interesting to take a look and see what's actually happening in a few countries. So what I'll do now is show you a couple of the categories of innovations we're seeing that are being applied to NCDs. Quick caveat again is the N is pretty small here at this point. There's probably more programs, but of the ones that we have documented, we've probably 35 or 40 programs. And the other caveat is a lot of them are in India. Partially we have a selection bias because we've got a great partner in India that's been doing a lot of documentation there. There probably also are a lot of it's a big country, right? So there's a lot of programs going on there, and there's a lot of innovation. But it's going to be interesting to see as we document in other countries what this looks like in other places. So I've just mapped these against the care continuum because I think they tend to address different parts of the continuum. We're seeing mobile clinics. This is, of course, not new. There's mobile clinics that address communicable diseases, but we're starting to see some programs that are using mobile clinics particularly for NCDs, and they tend to be doing some prevention, but a lot of it is for diagnostic as well as ongoing monitoring. We're seeing the use of mobile health and information and communications technology, a little bit of beginnings here to do ongoing monitoring of patients, both to communicate back to the patients, but also to begin to send bio data on patients to track them over time, things like blood pressure readings and blood sugar counts and things like that. In terms of acute treatment, we are seeing more telemedicine and call centers that are cropping up, and they typically don't say that their main focus is non-communicable disease, but because they're tend to treat acute patients, a lot of the volume they're seeing is actually for non-communicable disease. So I think it's an interesting model that sort of, again, gets at this challenge of not having physicians in underserved areas. And then we're starting to see a few private chains, especially in countries or regions that have really good government financing, that are cropping up to do things like dialysis. And then finally, we are seeing, is mainly in India, but there probably is happening in some other countries, integrated, very specialized centers that are across the entire continuum of care, but for one disease, like diabetes or eye care. So I'll just give a couple of examples here of what some of these look like. In terms of mobile clinics, the one I'll mention is actually HMRI, which is in Andhra Pradesh, India. And this is actually a pretty large-scale program of mobile clinics that go out to rural villages on a sort of regular basis. Interestingly, they actually do care for pregnant women as well, because pregnant women also need care on a sort of regular basis. Obviously, they're antenatal screenings, but they also do screenings for chronic illnesses, and then they actually go on to do the ongoing monitoring of patients, since they're scheduled to go back to villages every couple of months. And this program is actually paid for by the state, which is interesting. So that's why it's been able to scale up so quickly. But I think the fact that they are combining maternal child health with chronic illness is interesting, because there are some similarities in terms of the need there. In terms of remote monitoring of patients, what we are finding here is, frankly, more research projects. Microsoft Research is actually sponsoring some of these, and what they're trying to do is trying to figure out ways to create devices that patients can keep with them to monitor their actual bio data, and then that data can then be sent directly to systems. In some cases, like in this case of Medinet, which is in the Caribbean, they're actually creating mechanisms so that the data can be analyzed automatically, and then responses can be sent directly to providers if there's a real problem with a patient, or even text messages to patients if it looks like their different symptoms are getting out of control. So interesting. I think this remains to be seen. I know some of this work is being done also in OECD countries, but it'll be a question about whether information communications technology can be better used in the developing world to track people over time. In terms of telemedicine and call centers, again, this is addressing the lack of trained providers in rural areas. It's a little different than the mobile clinics, though. The mobile clinics allow for more focus on the monitoring over time, because the vans are going out on a regular scheduled basis, whereas telemedicine and call centers is much more patient-driven, so it tends to be used for more acute care. There's a couple of interesting, these are actually franchises of telemedicine clinics, such as World Health Partners, which is in Uttar Pradesh, India, and Sehat First, which is in Pakistan. And they are just starting to grow. So it will be interesting to see if this model of telemedicine is actually starts to expand, and if it really does begin to encompass more NCDs. Here I might add that I think these guys have been more focused, even though they get a lot of volume that's non-communicable disease. I think they've been more focused because of the donors that support them on communicable diseases and maternal child health. So they probably would benefit from better standards and protocols on NCDs, because they are getting volumes there. Then it's interesting to see that there's some private chains that have popped up in places like Brazil and parts of India. And this is really in response to governments who've decided that they can't provide certain services within government centers. And dialysis seems to be one that is a big need that governments find that they can't provide directly. And in Brazil, where they have a good health financing system, they're actually paying for this care. You can see that NephroCare, actually 90% of their patients are covered by SUS, the Brazilian health system. But it's a private company that's formed this chain that's pretty standardized of dialysis clinics. In Andhra Pradesh, which is one of the sort of most forward-thinking states in India on health. They've actually put out an RFP and ended up signing an MOU with a German company to build a bunch of dialysis centers in public clinics, and this is actually going to be on a build, operate, transfer basis. So eventually, these will become public sector dialysis clinics. So it'll be interesting to see if more countries begin to do this kind of purchasing from private providers. And then finally, I think these examples of integrated care across the continuum for one disease are quite interesting. They tend to be very vertical, which is interesting because when we think about NCDs, we tend to think about health systems and how it won't be as vertical as the communicable diseases have been accused of being. But what you are seeing is complete end-to-end care for things like eye issues and urology and heart care and diabetes, especially in India. And these models tend to be very high volume, which allows them to lower costs. And they're often using cross-subsidies to pay for the poor. So they bring in some wealthy people, but they cross-subsidize to provide free or low-cost care to the poor. A lot of them are operating as for-profit institutions, although some are nonprofits. And many are sort of mainly single-site. But some are beginning to replicate in multiple locations, which I think is interesting for franchising. What's interesting is often they are doing everything from going out into rural villages to find cases and do diagnosis, all the way through the monitoring, the treatment, and even kind of high-end research, all in one under one roof. And one program that we've actually done a case study of, if you're interested, is called Dr. Mohan's Diabetes Specialty Center. And this is not a franchise, but it is a chain, a private company operating 7 facilities in southern India. And they provide the full continuum of diabetic care, about between 350 and 600 patients a day across all their facilities. It's highly standardized. Apparently, they have 19 standard protocol manuals. And because of all these standardized procedures, they have been able to replicate at these 6 other locations. And they're using sophisticated electronic medical records. They are actually using telemedicine and mobile vans to go out to rural villages. They're actually funded mostly by out-of-pocket payments and probably a little bit of private insurance. But they do have a foundation that covers some of their poor patients. So this, I think, is a particularly interesting model because this is a place where you've got a lot care really standardized for one disease that would benefit from these kinds of standard procedures. Interesting to see whether others will follow in this vein. So just finally to leave you with a few questions to consider, I guess, can developing countries leapfrog OECD countries and the use of things like mHealth and telemedicine and remote patient monitoring for NCDs? What will be the impact if we start getting vertical programs for NCDs, which is, I don't think, something people really have necessarily expected would happen. One argument is it could be highly efficient, but it also could begin to fragment the delivery system, and you might end up getting redundancies in parts of the care continuum. For example, I saw when I was actually in southern India, there were different programs. There was an eye care program that had mobile vans that went out to diagnose people that needed cataract surgery, et cetera. And there are similar mobile vans that are going out to do other things. So is that a bad use of resources to have different non-communicable diseases focused doing the same parts of the continuum? And then I think the question of whether governments are really going to start paying for this is a big issue. You can envision more vouchers for episodes of care, as we've seen for safe deliveries in places like Kenya and Uganda. Could that begin to transfer to non-communicable diseases, maybe a voucher for diabetic care? Will governments begin to do more contracting or concessions for specific services like dialysis? And will we start to see more comprehensive national health insurance now that the World Health Organization's put out their latest report on health financing? Will we see that kind of coverage that will allow for more evolution of models for NCDs? And then I think finally, a big question, I think Nikki's going to address this next, is will the social franchise model emerge as a way to standardize and improve the quality of care for existing private providers. And I think this is a real potential opportunity and one that's really needed. And I hope that those of you that work in social franchising will seriously consider it. I'm curious to hear what Nikki has to say about it. Thank you. Thanks.
Gina, thank you very much. Let me now invite Nikki Charman of PSI to present on social franchising.
Good afternoon, everybody. It's wonderful to be here. Thank you very much for inviting me. So I'm going to talk about social franchising and NCDs. The outline of my presentation is going to be following this structure. I'm going to talk about social franchising in PSI and describe that. I'm going to describe our work in non-communicable diseases as well. And I'm going to discuss the application of social franchising to NCDs. So that's the outline. The main 2 points I'm going to try and make are that we need to engage with the private sector when talking about NCDs, and social franchising is a mechanism that can help us work with the private sector. So what is a social franchise, hey? In PSR, we worked at the global health definition of a social franchise. So rather than me read that out, Jen, could you please read it out for us?
Sure. Social franchise encompasses a network of private health practitioners linked through contracts to provide socially beneficial services under our common brand.
So this is the definition we work to. It has several characteristics. The outlets are owner-operated. We provide clinical services. Those services are standardized, and payment is for services provided through the network. That tends to be the definition we work to. But I know several of you in the room also work in social franchising. So how else would you describe social franchising? Could somebody please tell me what you think are the bones of social franchising? And Francois, you've got your head down. Francois worked in franchising for many years.
The equivalent of the way we define social marketing, which is the use of commercial franchising techniques to increase the uptake of essential health services and improve their quality.
Great. Yes.
That would be
That's
one.
it, basically. Oops. A social franchise network is a service delivery mechanism working with the private sector to improve health service delivery through the private sector using commercial techniques. So in PSI, our social franchise networks work to the 4 goals of social franchising as defined by the global health community, chaperoned by the global health group in UCSF. So the goals that we have outlined for social franchising are to increase access, quality, cost effectiveness, and equity of the service delivery channels when serving those in need. So when you look at PSI and social franchising globally, there are 52 social franchise networks around the world, according to the Global Health Group Compendium. PSI operates 22 of those networks, and MSI operates 10 of those networks, and then there are 20 other agencies working with social franchise networks as well. So there's a rich world of experience out there in social franchising, and there has been a steady increase in the engagement on the social franchising agenda over the past 10 years. This is a list of PSI social franchise networks. Please squint, because I think it's probably really small. Basically, we began working in franchising in Asia about 15 years ago, and you can see here there's a cluster of, we have the sort of largest number of franchisees in our networks in Asia. We then moved to Africa, and more recently we're working in Latin America, establishing franchise networks there. We have 14 brands across our 22 networks responding to the local markets in which those franchises are operating, but there is a definite pattern developing around regional branding. You can see the Sun Quality Health Network in Asia, there's Red Segura in Latin America, and there is ProFam in Africa. So when it comes to the types of franchisees that we work with, we typically work with GPs and physicians through clinics, but increasingly we're moving down through the provider chain to more informal providers to ensure access at sort of the front line of where our target groups go for their health services. So increasingly we're working with pharmacies and community health workers. There are 8 service packages that we offer through our franchise networks. Typically, our networks have been established with family planning funding, and you can see that most of the franchise networks operate to provide family planning services, but we're trying to broaden the offering across all the networks. We still have a long way to go on this, but this is our intention, to increase the number of services through a franchise network. So this is a Myanmar example, Sun Quality Health in Myanmar. They effectively, over time, have incrementally added services to improve their service offering for the communities in which the franchise network is operating. And you can see it started off with family planning, then moved into, malaria, and TB. And more recently, they're providing ART. So this graph describes the payment mechanisms through our franchise networks. PSIs on the left, typically payment for services out of pocket, but increasingly we're working with vouchers, insurance, and what else? Government reimbursement. But we have a long way to go still on that front as well. We're trying on that front. So when we think about social franchising and its application to the NCD agenda, in a very general terms, there are probably 2 main ways that we can think that there is applicability. One is the operating system. A franchise network basically provides a franchisee with an operating system, which effectively are the quality standards that the franchisee works to. When we talk about NCDs, we talk about standardization of services through private providers, and there's a natural alignment there on that agenda. Similarly, a franchise is comprised of a support system. A franchisor provides support to the franchisees. This, again, is along the lines of training, capacity building, subsidized supplies, and commodities. Again, within the NCD agenda, there is a need to probably support the private sector with these elements, and the franchise mechanism is a way to do that. And then when thinking about our work in franchising, there are some health areas which typically have activities that might align with elements of areas to improve within NCD health service delivery. So if you look at this table here, on the right-hand side are sort of WHO recommendations for strengthening health service delivery to better meet the needs of NCDs. And you can see on the left that, in fact, for example, in Myanmar's TB program, where we provide TB dots through the franchise network, there are very clear areas of alignment with our current activities and what would be needed for working on an NCD agenda. Similarly, in the area of reproductive health, again, on the right are WHO recommendations for strengthening health service delivery to meet NCD needs. And then on the left, you have activities that take place within our reproductive health programs going through our franchise networks, which similarly do align with what's needed to address NCDs. So within the existing franchise portfolio of services, there are lessons to be learned as to how we can apply our franchise networks to the NCD agenda. And then PSI is increasingly thinking about working on the NCD agenda, and we're very, very interested in this. And organically, our programs are already responding to it. We have 3 programs working on cervical cancer, which have naturally evolved out of the existing RH activities to do with IUD service provision and STI service provision. So it's a natural piggybacking onto the existing infrastructure, social franchising infrastructure. So, and then in Cambodia, again, piggybacking on existing activities within the franchise network there. There is no funding for this at the moment, but the team are looking to get funding to pilot an initiative to diagnose and manage hypertension, because it's a growing issue in the Cambodia context. So there are several trends in the social franchising area of operations which imply that franchising can not only can sort of respond to the NCD agenda. One of them is following consumer needs. Increasingly, our networks are really doing their planning to make sure they're responding to the disease burden in the context in which they're working. And putting the consumer at the center of what they do will naturally result in them having to think about working on NCDs. as you saw earlier, we need to emphasize integration across our networks. We're not there yet, but it's a big agenda item for us. And as we integrate, we will see the need to get involved in NCDs as well. Focusing on frontline providers, as we move our networks down and tear them down into the poorer and more rural communities, we'll increasingly develop mechanisms by which we can work at the front line on NCDs as well. We're trying to make our franchise networks work better within the context of the whole health system. This is really important. The communities refer into the franchise networks, and then the franchisees, the private providers, need to be able to refer on to specialists within the public or the private sector up through the chain. And this goes to the continuum of care that were mentioned by Gina and Rebecca. And then experimenting with alternative financing mechanisms. Increasingly, our networks are working out how to include more marginalized communities within the health service delivery channels. And as we do this, this would apply also to helping support the NCD agenda. So these are some issues to consider that I know Rebecca and Gina have also raised, but I'll raise them again so we can discuss them. But how do we motivate providers for long-term chronic care? There is a lot of time and investment in that, and we're getting more thoughtful about how we motivate providers and how we encourage their behavior, but this will be a challenge. Then coordinating across the continuum of care, rewarding providers in the network to engage with the context, this health system context in which they operate, and then finally addressing the costs of chronic illness. This could be an issue for social franchising in the future. So that's the whiz through of my presentation so that we can get onto a juicy discussion. But just again, to reinforce the two main points, we need to engage with the private sector, and social franchising is a mechanism that can be used to do so. So thank you very much. I look forward to talking with you.
Rebecca, Gina, and Nikki, thank you very much for providing both an overview of the NCD challenge in developing countries, a sense of some of the private sector solutions, not only for NCDs, but more generally in the health sector that are out there, and also for an overview of the social franchising model and how it can be applied to NCDs. We have some time for questions and discussion, so while those of you are formulating your questions, let me start with one for all three of the panelists. And I think all of you, one way or another, mentioned the issue of demand for these services. And I think, Rebecca, it was you who said that people may be reluctant to pay for the preventive care that could be provided, the preventive screenings, or maybe it was Gina, maybe it was all three of you, one way or the other. But I wanted to ask, what lessons you've learned from some, other experiences in terms of maybe the social marketing around how you get people to prioritize coming into, how you get people to prioritize paying for the private sector, prevention methods that may be out there. So just kind of thinking, instead of not on the provider side, but, on the demand side, how do you kind of raise awareness and encourage that kind of, demand for some of these services? I guess I'm thinking about prevention because that was something that was said, but, kind of across the spectrum.
I think you have to look at to assess the market and understand willingness to pay within the context of the market, and make sure your services are fitting within the willingness to pay of your target audience. And then if they're not, then you work out mechanisms, financing mechanisms to help motivate their behavior. Or it comes down to marketing the service to appeal to the target audience, basically. Yeah.
I think it's also interesting to think about that question from the perspective of what we know about people's willingness and how they get screenings, and incentivizing this kind of preventive behavior in wealthier countries like our own. And I think what we know is that people are not that good, even people with means and people who know they're supposed to get screenings are not that good about proactively going and getting them. Even people who know they should get blood pressure checks and mammograms and things like that don't always do it without a little bit of a push. So I think there are sort of multiple barriers to get people to do screenings, and we'll have to think really seriously about this. I think we've seen some models. I used to work for Kaiser Permanente here in California, but it is in several markets in the U.S., which is well known for delivering chronic care quite well. And the model they use, of course, is that they really sort of take over control of the patient's care, and they think of themselves as being responsible for both the cost and the quality of that care for a long period of time. And therefore, the provider has the incentive to do the screenings and to make sure that the patient gets in and to remind them that they need to come and do something. And then the patient, all of their care is prepaid, and they don't pay for those kinds of screenings. Typically, they wouldn't pay anything. There's sort of the incentive is around getting in for those very high value-added screenings. Now, we're a long way from any model like that, I think, in most developing countries. But I think we need to be thinking about what we've learned about some of the challenges. And so clearly, we got to take away the cost barriers and for the patient, and we also have to give the provider the incentive, which could be around paying them to do the screenings, or giving them a longer term control over the patients. But I think this is going to be a challenge to figure this out.
This is a guess, but I envision, and I think there's probably there's research to be done on this, that there's latent demand that we're not tapping into already. That has to do with people experiencing symptoms, but potentially not actually putting it in terms of, oh, well, this is an indication of high blood pressure. But if we actually looked at individual healthcare seeking behavior, we'll find that much of it is likely to do with non-communicable disease. I'm thinking about particularly one experience that I had in a rural commune in central Vietnam, where I was speaking with people at the healthcare center who told me that in that community, everyone was scared of stroke. And asked why, they said that there were a few examples of people who had had strokes, mostly elderly people, but it was so catastrophic, and it was such a strong experience for people within that community that people said that when they're scared of stroke. And so that's a matter of some degree of awareness around the disease, but just likely some behaviors around seeking care, but likely not necessarily appropriate or following effective protocols. But we don't think we have to look too hard to find people who are going to want care for non-communicable disease.
Lots of questions here, both around the table and in the back. When I call on you, let me ask you to please state your name and your affiliation, if any. If you're in the front, we're trying to capture this on web and audio, so let me ask you to please turn on your mic. And if you're in the back, please wait for one of the microphones to come to you. So yes, please, over here.
Hi, enjoyed the very interesting presentations. My name is Mindy Reiser. I'm a sociologist and have worked in various parts of the world. I'm very concerned about the quality follow-up and how rigorously this is done. It's fine to have in principle all the protocols and the manuals, but are there any good evaluations? When you have a far-flung series of franchisees, who is really monitoring what's going on? Are the physicians following the protocols? Are they updating their skills? That's really critical.
That sounds like a question for Nikki, so I'll turn to you first.
So we have quality assurance processes in place, including in-country monthly supervision, quarterly supervision, annual audits, and then global audits of independent auditors coming into our platforms. We typically began being more rigorous around the family planning agenda, because that's the oldest agenda, and we're expanding this rigor into all the other health areas. But it's very much at the forefront of our operations. And in fact, even when marketing with providers, a provider behavior is basically following a quality standard. And so when we market anything to the providers, it's about how to get them to follow quality standards. And that's what we think about all the time. And we have Julie here, who works on the quality agenda, sitting next to Jen. Her job is basically to sort of work with the team to ensure the franchisees follow the quality standards globally and in country, with the support of the in-country organizations. It's not perfect, but it's discipline and rigor is there.
Yes, over here on my left, please.
Hello, my name is Dave Brown from the National Council for International Visitors. And I guess the question I'd have is, could you discuss any of the political or social challenges you've had in adoption or getting your program started in the various countries you've worked? And do you recognize any patterns that need to be addressed that you found kind of essentially grease the wheel so that you can move forward? Oh, and I just wondered if you had found any, in your experience over time with those challenges, if you found a good way of implementing or getting the right parties on board with a new way of doing things.
I think the question was around the social, political, and
social and
economic
political. Ultimately, you're bringing something new into a system, and you're coming from out of the country. How is it that you get people to buy in, or what challenges have you seen that have helped with your success over time?
My PSI colleagues can talk to this as well, but we make sure that we operate within the context of the national health policies and the national health systems, and we make sure we're at the table when at all policy agenda discussions. So we're seen as operating within the context of the health system and trying to be a good partner, basically. So these are our intentions. In some countries, it's a more natural discussion forum that takes place and a more welcoming one. In others, it's harder to be a good partner, but that's the intention, is that we're always working within the context of the health system.
Rebecca or Gina, would you like to address that at all, or? Okay.
I would just.
Can you hit your mic, please?
Okay. I'm Julie. I work with Nikki at PSI on social franchising. And I would just add to what Nikki said that we're not really perceived as bringing something new into the country, because we're actually working with existing infrastructure. We're working to strengthen the existing health system. And I think that's how we're perceived. And the branding part of it is a way for consumers to actually identify where they can go to get good quality services. And through franchising, we've created this quality assurance mechanism. So not only are we making good quality services available, but through the branding, we're telling consumers where they can go to get these good quality services within the existing infrastructure.
Thank you. Yes, there's a question here to the right in the back, please. And then I see another over here and then one over here. So,
hi, I'm Liz Griffith. I'm at the State Department, and I have two questions that I think are maybe related. It's really easy to see how, for instance, cervical cancer screening can be integrated into reproductive health services that are already being provided. The question is, what happens when someone tests positive? What happens next? And the second question, which I think is related, is how does this help sustainability so that this becomes something that the country can do within country?
So within Myanmar, I'll talk to Myanmar where they've introduced the services recently. When people test positive, they're using treatment, cryotherapy for precancerous lesions. If it's a more severe case, they have an ob-gynae specialist that they refer the client to for follow-up, and they're doing it with the support of the Ministry of Health and the specialists within the Ministry of Health. So there is a referral system there for more serious cases. Regarding sustainability, they've managed to keep the cost really low to the client and still motivate the provider by piggybacking it onto the RH program there. So when they are doing the IUD insertion or the STI screening, it's part of that process, and it's 50 cents, as I mentioned, for the client. So it's proving to be popular and in demand as a service, and during our work we find there are populations that aren't able to afford that 50 cents, then that's where vouchers can be used, and other mechanisms to encourage that population to enter into the health system and into the franchise network.
I would just add that I was thinking about that same issue a lot as I was preparing for this. And I think it's important to note that not all NCDs are created equal. We're sort of lumping them together as if they're all the same kind of disease, when really cancer is quite a bit different than something like hypertension or diabetes and how you would manage it. You could see how you could do mass screenings for cancer relatively inexpensively. But then the question is, yes, what do you do when you find a cancer case? And there, especially when the treatment is high cost. So the question is, do you start doing a lot of screenings when you don't necessarily have in place the health system to deal with what happens if you find it? Whereas things like, I think some of those diseases where if you could keep them under control by diagnosing them early and getting people on relatively low cost behavioral and other management routines, things like diabetes and hypertension, that you can see a little bit more maybe lending itself to franchising. Although I think it's interesting that you guys are doing cervical cancer and you've managed to figure out a way to link with the health system. But I think this is something we all need to be really thinking about. And I think we're lumping all NCDs together. Ultimately, we're not going to be able to do that. We're going to have to be able to think about this disease by disease.
I would add that I absolutely agree with Gina that we need to be refined about what approaches we're taking based on the particular trajectory of each disease, but that to suggest, oh, well, if we can't treat all diseases, then we just shouldn't start, is, I think, going to get us stuck. And that if we think about that continuum, this is why the continuum of care is so important, and this is why I added palliation in at the end, because even if we can't provide high-quality treatment, palliation is necessary for pain reduction. And I think that on human rights grounds, there is a tremendous amount of work to be done in terms of increasing access to palliative care. And this is relevant for HIV as well as for cancer. So that, I think that's just to say that there's always something that can be done, even if we don't need to go immediately to the high-end, most expensive interventions.
So yes, question over here on the right, please.
Françoise Armand, Cardinal Emerging Markets. I have a question about sustainability again, but more the financial sustainability of the franchise itself. Have you, Nikki and Julie, have you looked at, the types of costs that can be sort of recovered by the franchise itself through perhaps membership fees versus those costs that could be recovered by out-of-pocket payments because they're affordable versus those that definitely must continue to be supported by donors? And of course, I'm talking about countries where you don't have, universal insurance or some sort of, health financing for private sector services.
So cost effectiveness is on the agenda actually with our work in franchising, and we're increasingly trying to sort of work out how much you invest in a franchise network to get the provider to do the behavior you want them to do. It's not to overinvest in the franchise network is really a big message that we're working with our franchise networks on. So in relation to sustainability, we're trying to understand the costs that go into managing the franchise network versus the returns that come out of the network. We're trying to work out what motivates providers and what they're giving into the network, because even if they don't pay a fee, they're still subsidizing some of the services through the network, through their own time, etc. They might be donating time, donating facilities. So trying to understand where the costs lie in relation to managing the network and being more thoughtful about managing those costs is big on our agenda at the moment. And then in relation to sustainability, then that becomes subsidy, and how we manage that subsidy and who pays for that subsidy, again, is quite a complex discussion that we're working on, but we're very conscious that it's an important discussion. So it's sort of it's not a concrete answer, but it's basically, it's quite a complex subject. But understanding where the subsidy goes and what you're investing in for your returns is important in managing franchise networks.
So I think there was one question here at the end, and then I know one over here, and then I see some others in the back. So yes, please.
Thank you. Thank you for really excellent presentations. I'm Kitty Shidena. I'm Vice President of Health at United Way Worldwide, and we're looking at building collective impact in education, income, and health. Rebecca, you started off by indicating that there are social and economic and environmental determinants that affect health beyond individual choice. And I'm wondering whether this particular model has opportunities or has presented opportunities to work on the larger systemic issues. So when we look at prevention, there's a spectrum of managing a NCD, but there is also a spectrum within the prevention in terms of the ways that communities are constructed. So are there ways that perhaps, and this country doesn't do that particularly well either. So I'm wondering if in a different culture, sometimes there are actually some bigger perspectives on a holistic view of what affects people's health, perhaps in a way that's even better than in the US. So I'm wondering if you've run into that as well.
Yeah, that's an excellent question. It's sort of how to integrate health promotion activities into other sectors, and I'm thinking of, I'm not sure if I'm going to be able to describe this really effectively, but Singapore has done some work on a sort of healthy Singapore approach, I believe, and I can look into more information for that if you'd like, that looks at approaches to urban planning that include, bike lanes and making sure that sidewalks are safe to walk on, which sounds somewhat basic, but in several large Asian countries, it's actually difficult. In big urban areas, it's actually difficult to walk on the sidewalk. So to integrate, those approaches to health promotion into urban planning, there's some work that's been done in Asia on that. Another thing is that there are people who are talking about resilience to climate change and how to again, in some large Asian cities that are thinking about how to address environmental health risks through a sort of resilience to climate change perspective.
So yes, over here on the left, please.
Peter Levin. One of the slides may have been Gina put up and said that an Indian state had contracted with a dialysis company. How do you feel about this? I mean, is this what social marketing should do in a situation where there's both communicable and non-communicable diseases that can be reached more effectively with marketing? Is this how we would encourage an Indian state to spend its money?
It's a great question, and a lot of people are debating it right now. The particular state, Andhra Pradesh, has been on the forefront for a lot of things. The dialysis centers is kind of only one piece of it, but they have created health insurance covering below the poverty line for everyone, and it's a state of 80 million people, so this is not small, but they are covering very high-end tertiary care. So not even really secondary care, but like they're covering things like dialysis and serious heart conditions and things like that for the poor, which on the one hand is kind of admirable. On the other hand, the question is this really how they should be? The question you're asking, I think, is what a lot of people are asking. Should they be covering that? And at the same time, they're also the same state that is running those mobile clinics, sending them out to do maternal care and try to find people with chronic illnesses and treat them over time. So they are thinking about kind of, I think, the broad continuum, and they've really invested a lot in health and increased their health spending significantly. So on the one hand, you have to give them credit for really having thought about this, but I think a lot of people are asking the same question, where should coverage lie? Should it be for the highest end treatments, or should it be down the spectrum a bit?
Would you please turn on your mic there?
Oh, yeah, thank you. I'm Veronica from the DRC Embassy, and I'm not a chemist nor a doctor. I would like just to have a good understanding of this subject, because for me it is somewhere a little bit higher, something ideological, not. And I would like to have, if you don't find it very big, I would like to have a model impacting really my country. Something pragmatic which can be, what I can say, applied. Because we are a developing country without means. And Denis, 10th years, we had been talking about AIDS. And we're still talking about AIDS. And people still dying on it. Then now you've got something complicated, complex, I cannot understand. So I would like to have, I will leave my, my email, so you can maybe put in my email something which can help my country. Yeah.
Just to respond to that, rather than do it on email, I think that's a great concern. Like, oh gosh, like we've got so much else on our plate. What are we gonna now? Everyone's talking about something else. Resources are limited, particularly now in an environment and the policy level of like fiscal austerity. So how are we going to find the money for this? And I think a little bit of a historical perspective is important in terms of thinking about what happened with HIV, is that 10 years or more years ago with HIV, people were saying HIV is way too complicated. There's no way that we're going to be able to get large numbers of people onto a treatment which they're going to need to be on for the rest of their lives in order for it to really be effective. And the conversation around HIV has changed in many countries because of many factors. The financing has come in, the drugs are much more affordable, but people have also really focused on let's make it simple and scalable. And that's what we need to do with many NCDs, and I think it's very feasible, is how do we make this simple, scalable? So that work still needs to be done, but that's not to say that it's not feasible.
The only other thing I would add, I think that Rebecca's presentation highlighted how much benefit we could get from doing more prevention now in countries that maybe don't have as high a burden of NCDs. And I think that might be a really valuable use of time of researchers and implementers to think about for countries that are maybe not experiencing huge epidemics of NCDs just yet, but will soon if they don't do something. How do you do that, start that prevention early so that you don't end up with a lot of people who are obese and smoking and all the things that we know lead to the worst risk factors that will eventually be the highest cost and hardest to treat. So I certainly don't have the answers, but that would be one thing to consider thinking about.
So I think we're coming to time for the close of our session. What I think I'll do is take 2 or 3 questions, just we'll kind of take them together as a group and then ask our panelists to just, pick, the topic in there that is most relevant to their expertise and answer those. So I think there were 2 questions over here.
Hi, good afternoon. Thank you for the wonderful presentation. Like, as my colleague mentioned it here, in the third world country, it becomes like epidemics, like diabetes, CVD, cardiovascular disease, and so many other things. Like, the more infectious this goes down, like NCD is going up. So that's related to maybe the aging, one thing. Like, people are getting a little bit bonus from the infectious disease, Then also the multinational company, like the tobacco, Philip Morris, and they are losing business in the UK and here in Canada, many other places. So now their target market is like the third world countries. So China come up with a good until now they were a little bit behind, but now they are implementing policies like to curb the smoking and stuff like that. So once, like you showed in the picture, like by 2030, like it become like almost infectious disease go away. But it's also unlikely because they come up if we don't give them like proper attention. So how are your program is ready to tackle those problems in the future? Thank you.
Hi, I'm Maeve Quigley. I'm with Comonics International. I'd be really curious to hear about the business model behind the franchising system that PSI has. I don't know much about yours. I know about Comonics, Bangladesh Smiling Sun program. And I'd be curious to hear about the ownership and the long-term sustainability in terms of especially ensuring the continuity of the quality of care. Thanks. Anyone else?
Thank you, and we can take one more if there's one other question, burning question. No. Okay, so we have a question about the business model of social franchising and a question, I think, around the epidemiological transition and the challenge of dealing with both the burden of infectious disease and non-communicable disease at the same time. Why don't we start? We'll start here with Gina, and we'll just go down the row.
Great. Well, I'll leave the business model of franchising to my PSI counterparts, but I think that the points that you raised, the one that really resonated with me was the notion that tobacco companies have found their new market. And I think if there is going to be a discussion at the UN in September and around non-communicable disease, and countries are coming together to create some sort of a call to action and figure out what they can do about it, I think that and some other things like it need to be on the agenda for how do we prevent the imminently preventable. People don't have to be smoking the way they are, and we know about this, and there probably are some things we could do because those countries reside in our countries, and so I hope that this is something that the UN will actually take on and not just brush under the carpet. That's one thing. The other thing I would just close with is this was really fun and interesting to think about. It's frankly a new topic to me, and I suspect there's a lot of really great ideas around the table here, and so I hope we have more opportunities to have a dialogue about what might be done around NCDs in the developing world going forward.
So talking to the questions around social franchise model. In relation to ownership, we work with our local partner organizations in the countries that are operating, and they act as the franchisor, so they're responsible for the quality assurance processes in country, but they have lots of support from PSI in DC and in the regional offices in relation to standards, policies, protocols, procedures, and also so in setting those systems, but also in monitoring and auditing them, and also in managing adverse events. So there is the local franchisor organization supported by the PSI network, and there's cross support as well between franchisor platforms. In relation to continuity of care and sustainability, we are increasingly talking to local stakeholders such as governments to sort of work out what our role is in relation to the whole health system, and then talking about who's available to pay for any subsidy that's still required by that network in order to ensure quality of care. For example, in India last week, PSI India organized a workshop on franchising, which brought together 6 social marketing organizations working in franchising, plus government working on health and franchising. And in fact, as an outcome of that meeting, there was a commitment to have a working group to discuss how some of the services going through franchise networks could actually be contracted by the government and supported by the government. So this represents the sort of the discussion agenda that we'd like ideally all our platforms to be having, but different platforms are at different points in the spectrum on that discussion agenda, but that's the direction we should be thinking about.
I can't really add much more on the business model for social franchising, but just to go back to the question on, I think I heard you sort of asking a question about how do we deal with multiple disease burdens at the same time, and I think stronger health systems are what's necessary. That dealing with multiple building blocks of a health system, whether it's the health financing, the human the workforce, the information and surveillance systems, that supporting those elements of what makes a health system function will enable the integration to deal with both infectious diseases and communicable diseases. And one of I think what's really critical for non-communicable diseases, but it's also really important for the infectious diseases, is stronger surveillance. So that if nothing else, to get a really good handle on what the existing disease burden is in the country, to be able to make policy based on evidence, it's really critical.
Well, I hope you all will agree that we've been fortunate to have 3 excellent speakers this afternoon who have really not only provided an excellent overview, but also some provocative questions for us to think about and consider as we look toward the NCD Summit in September and beyond. And I want to thank Sally Cowell from PSI for suggesting we take on this topic. CSIS has run a high-level speaker series this spring that will be continuing through the later spring and into the summer, and it's a pleasure to be able to complement those kind of single speaker series with a panel like this, to be able to really dive down into some of the topics, and we look forward to doing that again. In fact, let me just mention that on April 14th, which is this Thursday at 4 p.m., from 4 until 6 p.m., we will be hosting a session here at CSIS on tobacco control. So not on social franchising, but really looking at the issues around tobacco control and how some of that will play out in the summit in September. Dr. Frieden from CDC will be speaking, followed by a roundtable discussion featuring speakers from CDC, international organizations, and the NGO sector. So I encourage you to sign up and attend as well. But right now, let me ask you to please join me in thanking our panelists this afternoon.